We move on to now the anesthesia management for meningomyelocele. Now you need to know, what is meningomyelocele? It is basically a type of neural tube defect which is characterized by protrusion of a cystic sac containing the spinal cord and meninges through a defect in the posterior part of the vertebral arch. It's a progressive neurological condition and the most common site is lumbosacral. So prior to delving, we need to understand the embryology in short. There is a primary neurulation, there is a secondary neurulation. So primary neurulation, what happens? It usually starts within 18 to 28 days post-fertilization. There is formation of a neural plate, which is a thickened ectoderm, dorsal midline. The edges get raised. It forms a groove or neural fold. And once by the end of 4th week of gestation, basically this fuses and forms a neural tube. So it starts at the cervical or the neck region and progresses bidirectionally. Now, from this into secondary neurulation, which will complete the process basically, there is formation of sacral and coccygeal regions, especially the phylum terminale and conus medullaris, and this process involves condensation and cavitation of the mesenchymal cells. So once we have understood that, we come to know that the neural tube which was being formed, right? This is the thing. The neural tube which was being formed, if there is a failure of closure of this, it will give rise to neural tube defects. Most common, Spina bifida. Others can be Anencephaly, which are much more severe forms, Encephalocele, Anencephaly, craniorachisis. The secondary neural tube defects can be diastematomyelia, sacral dysgenesis, sacral ergenesis, and others. We concentrate on spinal bifida. Now, this is a normal spine. As you can see, this is the posterior. This is the anterior. Continuous spinal column is there. Now, what happens? First is occulta. So, here you can see, you can appreciate this. See. Alright. Here you can see there is a defect in the posterior arch of the vertebra. As a result, there is no protrusion of any sac. So, this is occulta, hidden. It might present you with a small dimple of tuft of hair in that region. Now, this is meningocele. What happens? Here there is a cystic sac in which there is protrusion of the meninges. And meningomyelocele, here along with the meninges, you have a component of the spinal cord. So what are the causes of neural tube defects? It's multifactorial in origin. It can be because of certain maternal factors, environmental factors, certain genetic factors. Most common, folic acid deficiency. Especially if the mother is not taking folic acid supplements during the antenatal period, the child can have a higher incidence of developing meningomyelocele or neural tube defects. Intrauterine exposure to anti-epileptics such as valproic acid and carbamazepine, use of methotrexate and ovulation drugs, especially meningomyelocele raised incidence can be seen in IVF babies, maternal diabetes, obesity, consumption of caffeine, smoking and alcohol. Environmental factors, exposures to pesticides, other nitrate related compounds, and certain genetic factors if the mother is having trisomy 13, 18, VACTER and VACTERL syndromes. All right. How do you diagnose a meningomyelocele? Definitely you will understand something is there once you examine the child physically. Now we go into a prenatal and a postnatal. A prenatal diagnosis can be made by certain lab studies which can be done in the mother. So there is raised maternal serum alpha fetoprotein in the second trimester. This is one of the tests which is advocated. Or there is presence of alpha fetoprotein and acetylcholine in amniotic fluid. What imaging can you suggest? A fetal ultrasound at 18 weeks of gestation can help you to diagnose if there is presence of any neural tube defect antenatally. Now, what happens in the postnatal? Means the child is already born. You are suspecting some kind of a neural tube defect. How do you confirm it? MRI spine, diagnostic. Others is you can do a serial ultrasound of the brain, CT scan or MRI of brain to rule out concomitant hydrocephalus. This is always suggested. The patient with meningomyelocele has come to you. What are the various or the varieties or the conditions in which the child can present to you? First and foremost, it might be only a simple swelling at the back. The child is absolutely asymptomatic. Others, there can be Progressive neurological disorder. The child who was initially good can develop progressive paralysis or paresis of the lower limbs, associated with hydrocephalus in 80% of the cases. So there can be a gradual increase in the head size. Orthopedic problems, club foot, hip dislocation, kyphoscoliosis, 20% times in case of lumbosacral region. Neurodeficits, as I already mentioned, paraparesis, paraplegia, can have associated genitourinary dysfunction, incontinence of bowel and bladder. Complications which can arise in a later stage might be because of infection, neurologic bladder, 90% of the times it is seen. They can have pressure sores and skin irritations because having paraparesis and other conditions. Also, you can expect latex allergy in 65% to 70% of these kiddos. So, which is the most common anomaly which you will think about if a child presents to you with meningomyelocele? First and foremost, we go stepwise. CNS. Meningomyelocele, neurological, think about CNS first. Hydrocephalus, 80% times. Arnold Chiari type 2 malformation, many a time seen. Can have craniofacial clefts, Klippel-Feil syndrome. Airway can have associated facial clefts. Cardiovascular, associated atrial septal defect, ventricular septal defect. GIT, anorectal malformations, umbilical hernias. Genitourinary can have UDT, that is undescended testis, bladder extrophy, neurogenic bladder in 90% of the kiddos. Hydronephrosis, many a times they can have a solitary kidney. Musculoskeletal, kyphoscoliosis, CTEV, hip dislocations. VACTERL, a very important group wherein there is vertebral, anal, cardiac, tracheoesophageal defects, renal defects, limb anomalies. You can also think about OIES complex, that is Encephalocele, imperforate anus, extrophy, spinal anomalies. So usually what happens if a child comes to you with these syndromes or these conditions for some other form of surgery, you need to rule out MMC in them. So, which is the most common anomaly you will expect? Arnold Chiari malformation type 2, 5 to 30%. What happens in this is there is cerebellar hypoplasia, there is caudal displacement of the medulla and the fourth ventricle through the foramen magnum. As a result, there is disruption of the brainstem vascular supply and it affects the lower cranial nerves, resulting the child can present to you with vocal cord paralysis. There can be stridor, pulmonary aspiration as a result. There will be abnormal responses to hypoxia and hypercarbia because the respiratory center is being affected. Now, another condition is Klippel-Feil syndrome. In this, there is congenital fusion of two or more cervical vertebrae. So this leads to a restricted neck movement. The child usually has a short webbed neck, a low hairline. There will be kind of no neck. Low hairline. So you have to suspect Klippel-Feil syndrome. These kids can have difficult positioning during intubation. Now, what is the prevalence of meningomyelocele? Around 0.4, 1 per 1,000 live births overall. In India, it is much more, much higher, 4 to 5. In fact, we see a lot of meningomyelocele conditions in India because of folic acid deficiency or non-supplementation of folic acid during the antenatal period to the mother. Now, what is the risk? Suppose if you have already had a child who has been born to you with meningomyelocele. Now, the second sibling, the percentage incidence increases by 3.2%. If you have 2 kids, then it is definitely around increases by 10%. Point to be taken into consideration. The child has come to you. What are the points which you will consider when you are doing a preoperative assessment of this child? So history, definitely. Antenatal history is of significance. What medicines the mother took, any exposure to all other factors which I had mentioned. Birthing history, at the time of birth, were there any swelling which was noticed by the doctors or the medical staff? Whether there is presence of any similar defect in other siblings? How are the limb movements of the child? How are the bowel, bladder, continence of the child? Systemic examination, you need a detailed neurological examination to rule out associated hydrocephalus and other systemic anomalies, as I mentioned earlier. Also, local examination, that is the size and the site of your meningomyelocele or the neural tube defect. What is the shape of the defect? Whether there is any CSF leak or not. Specific investigations. So, coming to the lab investigations, routine investigations like a complete blood count,